Hi, students, and welcome to Chapter 12, the final chapter lecture for Public Health 422. I am going to be covering the idea of cultural competence and the chapter being titled Being Culturally Competent. There is a movement afoot to lead professionals toward not just having awareness of competence, in being culturally appropriate, but being humble enough to recognize that for public health, healthcare, and many other social service related fields of work, we have to accept that culture isn't always shared. And it is not something that is always intuitively known. And the idea or the concept of cultural competence gained widespread attention in public health and medicine, starting in the 80s, the 1980s through the 1990s, and really started to bring forth this idea of disparity and differences and inequities within the healthcare and public health systems. That led to health disparities and health inequities and differences, not just differences, but significant outcomes, poor health outcomes for ethnic minorities. And so culture, as we have learned and discussed in this course, is rooted in perception and history and signals and language and behavior and a multitude of factors. And so I want to introduce to you a concept called cultural humility. And there's a lot of debate in the research between cultural competency and cultural humility. Cultural humility is the ability to maintain an interpersonal stance that is open to others, all cultures, while accepting that cultural competence as the ability to interact effectively with people of different cultures. So that's more of a learned or taught condition. Like I can be functionally open to learn and be knowledgeable about other cultures, but cultural humility leads with an openness in spirit of recognizing that you will never understand the full constructs of other people's cultures, but it's not a fixated thing or it's not a static type of thing. So as professionals, we should be able to claim both competency and humility, or continually working towards competency and humility, recognizing that both are a lifelong journey. We never arrive. It's without an end point. And it's the difference between knowing about culture and being in a state of selflessness and altruism to accept what we don't know about others, but wanting to learn and experience as deeply as we can. In my estimation, after being in the field for 21 years, it's not enough to be culturally competent. We have to be culturally humble too. Now, at the federal level, there have been many strides over the past 20 years to bring to fruition a cultural basis for healthcare and public health. And I would say even starting more so in 2002 to 2006, there was a huge push federally on health disparities and health inequities arising from the lack of attention to cultural factors. And so they developed at the time the culturally and linguistically appropriate services, or CLAS standards, to help organizations and agencies shape and reshape their approach to cultural competence and cultural humility. So the CLAS standards, their purpose is to basically provide a way for the quality of services provided to all individuals to be appropriate and culturally and linguistically appropriate. Because when they are, we know there's concordance there, and that ultimately helps to reduce health disparities and health inequities and gets us closer to that goal of achieving health equity. Now, there are 15 CLAS standards in its current iteration. These are, think of these as actions to help understand the role of culture in health, and these are not exhaustive by any means. There's just so much more to cultural relevance and competence and humility than these 15 standards apply. Now, the list in the Edberg text is a little out of date, so I've posted a link in Blackboard to the website with the current standards as they exist today. It's the thinkculturalhealth.hhs.gov web link. So the principal standard for a class is to provide effective, equitable, understandable, and respectful quality care and services that are responsive to diverse cultural health beliefs and practices, preferred languages, health literacy, and other communication needs. That's a broad standard and can look a lot of different ways in practice and in a clinic setting or in a public health setting. The next 3 standards apply to governance and leadership and workforce. So there's 3 standards to advance and sustain organizational governance and leadership that promotes class and health equity through policy, practices, and allocated resources. That is huge. If you don't have leadership buy-in, if you don't have governance practices that employ and implore the use of cultural and linguistic appropriate resources, you're going to fail from the very beginning. So advancing and sustaining that governance and leadership is critical to this process, to agencies and organizations to achieve health equity, right? That's the end goal. The second standard is to recruit, promote, and support a culturally and linguistically diverse governance, leadership, and workforce that are responsive to the population in the service area. If I go to my hospital or my doctor's office or public health department or participate in a community-based program, public health program, health promotion program, but I don't see people who look like me or talk like me or believe like me, I'm going to feel like there's a disconnect and I might not engage fully. So concordance is extremely critical to this process as well. So you want to recruit and promote and support people that look like the people you're serving, right? There has to be concordance there. And the third standard is to educate and train governance, leadership, and workforce in culturally and linguistically appropriate policies and practices on an ongoing basis. This work is never done. It goes on and on and on. And that's why I think right now we're seeing a lot of healthcare systems, academics or universities, other government agencies hiring for diversity, equity, and inclusion officers to kind of elevate these class standards in a more functional way. It's sad that the last 4 years has really been the impetus for that to happen, but I'm glad it's happening. The next section of standards is for communication and language assistance. There are 4 principles there, which the first one is to offer language assistance to individuals who have limited English proficiency or other communication needs at no cost to them, to facilitate timely access to all healthcare services. This goes for people who are vision impaired, people who have hearing loss, people who may use American Sign Language, people who speak a variety of different languages. It is incumbent upon every institution and agency that seeks to provide health and well-being and treatment to others to reduce the burden of disease must be able to be linguistically appropriate and to communicate in an appropriate way in their language. The second principle is to inform all individuals of the availability of that language assistance and services so that they can access those services in their preferred language, both verbally and in writing. Most agencies and organizations will contract with an external vendor or contractor to provide these services. There are national and international companies that provide this service to government. I know when I worked at the Virginia Department of Health, we had a proprio line that we could call if we needed to verbally communicate with somebody with a different language. And it basically would be like a phone translation. You'd put it on speakerphone. I would ask a question, they translate, answer, translate. So we could have communication. The third principle is to ensure the competence of individuals providing language assistance, recognizing that the use of untrained individuals and or minors as interpreters should be absolutely avoided. It's a really tough situation when a child is put in a situation to translate, and that should not be their responsibility. Although I will say, culturally speaking, I had an experience where I was doing key informant interviews with maternal and child health population in Southwest Virginia, and several of the interviews I did with Spanish-speaking women, their husbands were also present with them, and at times you could tell would signal to their spouse kind of on how to respond to the question that was being answered. So, there are cultural factors that play into even something like an interview, with a family member, but still providing them the opportunity to have appropriate trained translators, for that experience or for that interview. The fourth principle is to provide easy to understand print materials or multimedia signage in the languages commonly used by populations in that service area. If I'm working in an area where there's a large Creole population or a large Filipino population, I should have materials in Creole and in Tagalog. So it's very important that you know your community, you know the populations that exist, and what the language needs might be. The next section of standards, class standards, relate to engagement, continuous improvement, and accountability. So these principles are about establishing cultural and linguistic appropriate goals, policies, and management accountability, that they are infused through the organization's planning and operational processes. That means there's ongoing assessments of the organization's class-related activities. There's integration, seeking to integrate these measures into continuous quality improvement activities. Another principle is about collecting reliable and accurate data to monitor and evaluate the impact of class on health equity and outcomes. Is what we're doing actually doing the thing we want it to do? That is a huge part of our work. And then is there a feedback loop? Does that inform service delivery? Does that improve service delivery? Does it change service delivery to be more culturally and linguistically appropriate? So conducting those regular assessments has to be an ongoing thing. It's not a one and done. When needs are identified, that doesn't mean they stay needs forever. New things pop up, right? So we use the results and our findings to make changes into our services to make sure that the systems don't perpetuate that disadvantage, that disconnect, but that become more culturally and linguistically appropriate and responsive. The other standards that apply to this category of engagement, continuous improvement, and accountability relate to partnership with the community. When you have that concordance with the community to design and implement and evaluate policies and practices and services to make sure and guarantee that they are appropriate, that's a win-win. You're going to get a lot of trust built and support built because of that. Now, inherently, there's going to be misunderstandings. You're going to have to anticipate that, and you should anticipate that. And so how do you navigate through conflict or grievances in a culturally and linguistically appropriate way, right? So we have to be ready to identify, prevent, and resolve conflicts or complaints, and seek the common ground. Seek to understand what you don't see, or maybe what you don't perceive. And the last principle is about communication of the organization's progress in implementing and sustaining class to all stakeholders, constituents, and the general public. So check out that link. to the hhs.gov site to learn more about class standards. They are sort of the federal level guidance for being culturally and linguistically appropriate in all services related to the federal government funding. Now, in 2006, Arthur Kleinman and Peter Benson introduced this idea of person-centered approach to cultural competence. And they posit that culture, as we have learned through the Edberg text, is not static, it's not uniform, and it isn't unaffected. Culture is inseparable to the economic and political and social, religious and psychological and biological conditions. Culture is a process through which ordinary activities and conditions take on an emotional tone and a moral meaning for participants, right? And so understanding how the cultural world affects and is affected by illness is the basis of our work as public health professionals. I want to say that again, because this is just really, really important. If you leave this class not knowing anything, is that understanding how the cultural world affects and is affected by illness is the basis of our work in public health. So Kleinman and Benson proposed several steps, 6 steps to pursuing this work. The first one is simply to understand and to ask about ethnic identity to determine what matters to the patient in the population. It is crucial to acknowledge and affirm a person's experience of ethnicity and illness. Sorry, dry throat. The second step is to evaluate what is at stake when facing an illness. Who is impacted? What resources are needed? Are there conflicting religious commitments? What is really at stake for that person or that population when facing whatever the problem is? The third step is to reconstruct the patient's understanding of their illness from a cultural lens, from a cultural perspective. So you ask them to explain their problem. What is the problem? What do you think is causing the problem? How serious do you think it is? Does it affect your mind and your body? What do you fear about the problem? What do you fear about the treatment? Right? So it's getting this idea of what are the perceptions around the problem. Step 4 is to also considering then the stresses and the supports that are in place for the problem or for the person's life, such as family tensions, work problems, financial difficulties, or personal anxieties. The 5th step is to examine culture in terms of influence on health relationships. So where's the bias? What implicit bias? Remember back in module 1 or the first week, I had you do Harvard's implicit bias test. Is there potentially an inappropriate or excessive use of technology or advanced technology interventions? Is there stereotyping at play? So really trying to understand what is influencing culturally within the health relationships, like between clinician and provider, or public health educator and community, or health director and community, or epidemiologist and community. The 6th step is to take into account the question of efficacy. Again, it doesn't work. Is what we're doing actually working? Is it bringing about the results that we anticipate and expect, or is it causing unintended side effects? Often well-meaning professionals overemphasize cultural differences, and it leads to mistaken ideas of or planning that if we can identify the cultural root of the problem, that we can fix it and solve it. Remember the story of the young Hmong patient with epilepsy that we evaluated early in the semester, and the little girl died because the culturally important factors were not addressed. And you all wrote appeal letters to that regard. So Kleinman and Benson described this person-centered or population-centered approach to be different than the class standards for cultural competency, because they put an emphasis on finding out what matters most to another person or group of people, they don't believe that's a technical skill. They believe that that is a fundamental element of the health relationship with a patient or a group of people. And this orientation has to be part of our public health professional sense of self, and how we use our interpersonal skills to become an important part of resourcing the patient or the group of people or the population. This is the main thrust, not a stereotype, right? We want to seek true understanding. We're not just looking at a case of whatever fill in the blank disease. We want to realize, well, what is it that they're facing? What is the danger? What is the uncertainty? What, are the barriers and the challenges? The opportunity for public health and healthcare is engagement. It's an essential moral task, as we pursue to find interventions that are going to be successful and that are ultimately going to reduce disparities and get us to a place of actually achieving health equity. Now, Edberg presents a third model, and continues forward in the chapter by establishing 5 principles for cultural competence. You can see a short list of those in box 12.2 on page 165 in the textbook, and there's also further explanation. So those principles go: Principle 1, culture and health are bound together in some way, as are culture and other domains of human life. It is an integrated phenomenon. And I think that Principle 1 kind of captures the essence of that intersection, that they're bound together, and it's an integrated phenomenon. Principle 2 is that culture is not an add-on or a set of traits or items that can just be, formulated or pulled together out of their cultural context. Cultural context is the foundation. It's not an add-on or an afterthought, right? It has to be foundational to our process. Principle 3 is cultural beliefs and patterns represent central tendencies more than homogeneous patterns. Culture is not static. Culture is not, a homogeneous, static fixture, right? It evolves and it adapts and it changes and it's influenced and it's impacted by a variety of different things. And so we have to realize that we not to get stuck in stereotypes, but to recognize that there are central tendencies, there are commonalities and similarities, but that's not uniform across the board for every culture. So Principle 4 is culture evolves, kind of already hit on that one, as part of the world in which we interact. What may have been true about a given culture, say 50 years ago, probably isn't true today, because people learn and people are affected by different people, or different experiences or disasters, you name it. And then the last principle is cultural competence is practical, everyday, and reality-based. That's a big one, because sometimes professionals, sorry, dry throat. Sometimes professionals don't see this as something they need to inculcate within them as a professional. I apologize, I'm not getting upset, I'm joking. So, the nuances to culture are truly local and time-bound, right? So even stories and things that you've read in the Edberg textbook have changed today in 2020. 2020 has changed so much of our culture, even here in the US. And it's fascinating to me, even in regards to like health promotion and health education around COVID-19 and things that I thought our culture in America valued, like science and technology and math and epidemiology, finding out that there's a large chunk of the US that doesn't believe in it and doesn't think it's trustworthy. So, I think to be culturally competent really means to be culturally humble, to recognize that we will never know it all. Um, and as public health professionals standing at this crossroads of culture and health, it's really with the drive, the passion, the mission to reduce the persistent inequities that cause some groups of people to have a higher burden of disease, and then especially among ethnic minorities. So the goal of this course was to understand how to think about relationships, specifically the relationship between cultures and health, because it doesn't happen to the extent it needs to in our modern day public health system. We can't take the one size fits all approach. And so again, this course really was about considering not what to think, or even in some sense why to think, but really how to think about culture and health and the relationship between the two and how they impact disparities and inequities. So it has been a pleasure to have such bright young women in this course this semester. As you probably could tell, it was my first time teaching this course, and I tried to make it as straightforward and simple as possible. It's easy to make a lot of these concepts hard and difficult to grasp, and so I hope that you are able to take some really good nuggets with you as you move on in your degree. I've emailed your peer-reviewed papers back to you, and so you have until December 14th to submit them along with your video presentation. There's one last chapter quiz for chapter 12 this week, due on Sunday the 13th, and then you're done. So please reach out if you have any questions. Keep the faith, finish strong. I am so proud of each of you. Again, if you have any questions or concern, please don't hesitate to reach out, and good luck with the rest of your assignments.